what we're hearing is that there is this hesitancy for people in the Black and Brown communities to feel comfortable with vaccinations, COVID vaccinations. I think as Black physicians, we fully understand where some of these concerns lay. So I was just hoping we could have a conversation where I can ask you, Dr. Vargas, what you know about COVID, what you know about the vaccine. Similarly, Dr. Teverbaugh, to see if we can answer some of the questions that rightfully so are lingering in our communities.
We're in the last leg of this marathon. We cannot drop the baton now. And so we knew very early on that we were going to be at risk for bad outcomes related to COVID. And as of today, so it's around, this is March 19th, 2021. So we're a year into this. And, we've lost so many people to the to the virus, that having this vaccine, which has now been available for 3 months, has been, really the last leg of this journey, which can really turn things around. But it's really important for us to understand that, the issue of getting the vaccine to folks is one which also is tied into a lot of the things that made this so bad for us in the first place. People talk about the higher risk for Black and Brown communities from dying from COVID-19. In the early phases, Black people were dying at a rate 3 to 1 compared to whites. If we look at the entire course of the disease over the year, it's been a 2 to 1 death rate for Black people compared to white people, and the same for Hispanic and Latinx compared to whites. But people don't seem to understand that this is not due to higher risk factors alone. And in fact, some of the things that we talk about, diabetes, hypertension, other things that in chronic diseases that may be putting people at higher risk, are mitigated when people actually get equal care and equal access to treatment. And there's a study by Dr. Otabenge out of NYU that showed that when Black and Brown people get into hospital care, they have the same or better outcomes compared to whites. Okay, so really what that tells us is that the disparities that we've been seeing in COVID-19 are disparities in access to care. There are disparities in the social factors that lead to worse health outcomes. And it's very similar to everything else we've seen. People will talk about this concept of laying bare. And COVID-19 laid bare. It exposed a lot of the social factors that have always been with us that have led to worse health outcomes for Black and Brown communities. So that really has been, one of the downsides. And we were talking a little bit earlier, about what has happened in Los Angeles County in terms of the excess death rates that we've seen. But bringing this fast forward to today, one of the benefits of where we are, at least in the United States, is that we now have access to a vaccine. And that vaccine is, there are three that are currently on the market as of today: Moderna, Pfizer, and Johnson & Johnson products. And two of them, have, very, very high efficacy. And the Johnson & Johnson is also efficacious in preventing people from having severe disease. And the data that we've seen so far from all three is that if you get the vaccine, people who've gotten the vaccine don't die from COVID. People who get the vaccine do not get severely ill and hospitalized from COVID. That's the great news. I mean, to have something like that available, we know how many of our people have died, is a blessing. And so as a physician and as a public health practitioner, we have to get our people as many of these vaccines as possible to not let that disparity happen. So I told you before, the disparity is because our people aren't getting the same care. If our people get the same care, there's no disparity. Okay, but when you have something available that saves lives and it's not equitably distributed, it actually widens disparities so that the healthier, wealthier people will get that benefit, and those who are suffering from disparities may not get that benefit, and therefore the disparity widens. Okay, And so with that being said, having 3 vaccines available is really essential to us making sure that these disparities don't persist and don't widen. And we actually have a real opportunity to close them if we get those people at higher risk the vaccine first. Okay, so that's kind of like just the overarching picture I want to set, for where I stand on this conversation. A few other, points on this in terms of the vaccine availability, and you'll hear about, different things about the vaccine. Let's not also get overconfident. Okay, what we also know about the vaccine is that the vaccine will prevent you from dying and will prevent you from getting severely ill. But if you get exposed, you can still carry the virus and potentially spread it to others. We don't know yet. So we cannot stop, and we must continue to push this message of social distancing, of washing your hands, of wearing this mask until our entire communities don't have the virus circulating anymore. The worst thing in the world, one of the hardest things that I had this week, I do a family Zoom with my family every Sunday. Our families, we're in New York, we're dispersed all over. I was telling Denise, Dr. Shervington, that I've got family in New Orleans, Florida, Atlanta, but we have been, in a good way, been able to come together every week. And fortunately, all of the seniors on our family Zoom have received their vaccines. But we've also had messages from family members in both places of people who have died this week. From our church in New York, and a friend of my mom's in Florida died after a time period in which they could have gotten both of their vaccine shots. Okay. So we have to understand that this is not over, but we have a lot of tools at our disposal. We're in the last leg of this marathon. We cannot drop the baton now. Okay. In fact, typically you have the fastest person run that last leg. So this is where we really have to really, buckle up and work hard to really deal with this.
Dr. Teverbaugh, what have you been experiencing in the community? I know that you work with the younger population, but I know they have families. What are you hearing? And just what do you think about the current situation we're in about the vaccine?
From both the community sector and then the school sector, I'm seeing a lot of impact and changes on our youth, and youth function within their families, right? So their community contacts and their families, and I also work with predominantly lower resource communities, right? And so that's where you really see the disparities in terms of access to care, and then also the disproportionate impact that COVID has had on families, and particularly families of color. We see our kids who may have had a number of traumas prior to COVID, have even more traumas, right? So family members dying, seeing family members have poor or negative experiences, either with the healthcare system or what the economic impacts that COVID has brought in terms of, as particularly in the New Orleans area, loss of income related to those family members who are part of the hospitality industries and other industries that closed down because of the shutdowns. I've seen that effect, and particularly in systems of care where they're a little bit more fragmented, again, lower resource, and you don't have as much access to care and preventive care, then we have this kind of overload of stress, right? And stressors, then there's not as much reserve that's left. And then also because there is not as much access to care, then there may be more hospitalizations, right? Even from a mental health perspective. And so it's been a cascade of factors. But I don't want to say that it's been all negative, because for a number of the reasons that Dr. Vargas mentioned in terms of other benefits of COVID, such as a Sunday family Zoom, right? So, and being at home more with your family. So increased communication, increased, just getting to know each other, right? The slowdown of the fast pace of life in general, which really gives you the opportunity to see that, oh, okay, well, I can spend more time and more quality time with people during COVID in some ways that I couldn't or didn't spend before COVID, and that's a part of that resilience that's been fostered as well during COVID. So a lot of different things across the spectrum, and with youth and their families from a mental health perspective, but those are just a few.
So, Dr. Vargas, what do you know about the vaccine? How it works? You know, for those of us who are physicians and we did immunology and we understand about antigens and antibodies, but now we're asking people who might not have that literacy to trust that a vaccine is helpful. Is there a way you can break it down for us so we understand what the vaccine is supposed to be doing?
Like I mentioned to you before, there are two types of vaccines, and there are three specific brands that are available. So Moderna and Pfizer are messenger RNA vaccines, and the Johnson and Johnson version is called the DNA vaccine. In plain talk, what that means is that these vaccines are providing our body with messages that actually have our body create proteins in our cells that look like coronavirus. Okay. So you're not injecting the virus, you're not injecting particles of the virus, but you're injecting components of messenger RNA or DNA that actually are the blueprint for how our body makes everything. Okay. And so these messages actually tell our body cells make a protein that looks like what's on the surface of the coronavirus. And our body cells make these proteins that can't cause the coronavirus disease, but can cause our immune system to say, this looks like coronavirus. And when I see it, I'm going to grab it and I'm going to have an immune response to destroy it. Okay. And so our bodies have white blood cells that are floating all through our bloodstream. And anytime we get an infection from a bacteria to a virus to any type of foreign body that comes into the bloodstream, our body's immune system will actually fight it in that manner. And one of the things that it does is it says, like you get any other type of cold or any other type of infection, this doesn't belong here, we're going to fight it. Now, the other thing it does outside of immediately fighting it is it creates an additional response that will allow you to remember it the next time you see it. Okay, so that's kind of immunology 101, how the human body works. And so the history of vaccination actually goes back to things that people learned in this country from people who were brought here from Africa as slaves. And that when they had diseases like smallpox and you saw a pus, you could take a little piece of that and you could put that in someone's nose or mouth or give them a cut and put it in it. And what we knew from our generational ancestors was that if you gave somebody a little bit of that and exposed it, that they would subsequently not get the worst disease. And that evolved into the science of understanding immunology. And that immunology is really what is driving vaccines today. Okay, vaccines have saved us as a human population from uncountable death and disease, from smallpox to other types of diseases which have often been eradicated, polio, things of that sort, where if you get enough people vaccinated, more people won't spread it. And that really prevents this from going all over. So that's how vaccines work. Vaccines have had a long history, and the science behind it right now is very strong and robust. And if anybody has a concern about taking it, you have to think about the alternative. We've lost over 500,000 people in this country right now. I've told you that death rate for us as African Americans is 2 to 1. And what we're finding is that when we vaccinate people, and the trials that have been conducted have had African Americans in these trials at very substantial and good numbers, and people who've gotten the vaccine in the trials haven't died. Okay, so the good news is that actually is something that we have strong evidence. Now, there's a question about, was this done too fast in this aspect of warp speed? And so when we talk about warp speed, what you have to understand is that the way that we actually develop, and what I'm going to do is I'm going to maybe share one slide here.
Yes, please.
But what this slide is going to show you is that although this vaccine was brought into production at a very fast rate, the science and the part of how we determine whether a vaccine is safe and does it work, that duration is the same as we've done for all vaccines, in this country. And so we have something called an advisory committee for immunization practices. They are not, elected officials. So I think there was a lot of concern about the prior administration, and the biases of different institutions that were controlled. But there's an external advisory committee that includes physicians from the National Medical Association, the Black Physicians Association, and others that really, review the data. And that committee reviews the data and tells us how we should actually submit, how we should actually provide these vaccines. In addition to that, there's the Food and Drug Administration, and they actually review the data from the trials and say, can this actually be authorized to be used and approved? So you have two governing bodies. One says, is the data and the science good? Does this work? And the other one says, okay, this is a good resource. Now, how do we get it out to folks? There are three phases of research that have to take place. And there's phase 1, 2, and 3. And the phases 1 really say we give this vaccine to healthy people, and does it cause any harm? And then phase 2, you give it to a greater number of people. And you also want to give it to people to see if you get the scientific response. So does it hurt anybody? Does it get your immune system to respond in a way? And you look at that data and you look at the blood. And then phase 3 is you give it to a larger number of people and you determine, does this actually prevent the disease? So those 3 phases of clinical trials is what's required for all drugs to be approved by the FDA, okay, to be authorized to even go out into the community. That process was the same for these vaccines as it was for everything else, and so that gives us some assurances that, this is safe, and does it actually prevent the disease? The traditional arm is these 3 phases of trials. Okay. Now, what often happens is preclinical development, the science of, determining whether or not a company even wants to make a vaccine, that typically takes years, and they have to decide whether or not they want to go down the road of doing the clinical trial. That part here often takes years, but for this, we made the decision right away when we saw how many people were dying that we need to go straight to clinical trials. So that's one of the ways that this differed. Okay, the other way that it differed is that production under the normal process typically does not start until after you finish phase 3 clinical trials. Most companies are not going to start producing vaccine until they know it's gone through all 3 phases. Okay, what was different here was that the government said, we'll pay you to start producing it now, because as soon as we get through the trials, whatever vaccines work, we want to make sure people get as soon as possible. So the production started early. So this process of preclinical time of deciding which ones to actually, make, that was different because we decided we knew we had to make this vaccine and do these trials right away. But there has been over 12 years of research for these types of vaccines that has taken place before these trials started. So the data for why this would be a good approach to use has already existed. And so the main difference about warp speed here is that, one, there was no hemming and hawing about whether or not we should make it. And then two, whether we should not start the trial. And then two, once we had the evidence, that we got through phase 1, they started producing it right away. Okay. And then the results from the trials, demonstrated that the outcomes they were looking for was severe disease and hospitalizations. And these trials have shown that when the people were in these studies, that people did not end up getting sick and hospitalized or dying. Although some people did get exposed and some people, did get the disease, the worst outcomes were not being seen. So the effectiveness of these were known from those trials. And I think the last part that I'll say on this is that we also have had these vaccines, being out and being distributed to millions of people. Okay, and so now we're collecting data. And so if you do get the vaccine, you're going to get something called vSafe, and you'll get a card. And we'll be able to report adverse events. And that's something that's also constantly being followed. And so to date, there hasn't been a severe number of adverse events that have disproportionately happened in people who have gotten the vaccine. And we're going to continue to watch that to make sure that moving forward, if there are any problems that we know ahead of time, but to date, there haven't been. And we know that once they vaccinated all the people in long-term care facilities, which were the first group to get vaccinated, those death rates went down.
Mm-hmm.
And I believe we're going to see the same thing. So at this point, I'm, confident recommending that people get it because we are in the midst of this crisis. And so we still have a long way to go to get everyone vaccinated. But those are the major differences. And that's kind of how vaccines work and why I feel it's important for us to understand that this is something that we have to really take seriously. And if you're eligible to get it.
Dr. Vargas, thank you so much for making the science accessible to those of us who, as he said, have not studied immunology. I get it. Dr. Teverbaugh gets it. I think we're both been vaccinated. I assume that you are too. And we've been fine. But, in our communities, in the Black community in particular, we always have these concerns. We've had a very tenuous relationship with science and research. And so, Dr. Teverbaugh, I'm wondering if you can share a little bit about what you understand, why we have concerns and what's being called hesitancy. It's just that we don't think that this is something safe for us because we have seemingly so many other experiences where we don't feel we can trust.
So there's that historical experience for Black people and people of color within science, right? So and it's an extensive legacy of things being labeled scientific that weren't necessarily scientific, right? The whole eugenics movement, where and characteristics that were given to us, or we were seen in certain scientific lights, and those studies used to perpetuate racism and racism against our communities. And we have specific scientific experiments where we were injected with things that were harmful to us, right? And were not given treatment when we thought we were given treatment, like the Tuskegee experiment, right? And these are long and enduring legacies, and they actually happened. And for us, we have family members who it's happened over and over within their lifetime, and so we have this new vaccine, and it's right up. It's like, what is this for? Like, and is it really safe for us? Right? And is this some grand conspiracy or scheme to further damage us? Right? And those are real concerns. I have family members who have said that they are not getting the vaccine because they are afraid that it is a conspiracy to further subjugate us, right, and to keep us from advancing and moving forward, and to harm our communities. So it's a thing. It's a very valid and real concern, and how we talk about it, how we address it is a big deal. There's power in shared experiences. And so those of us who have gotten the vaccine, social media is very effective in sharing our stories and what our individual responses have been to it. And also just the idea that because this is something that is disproportionately affecting us, that we are disproportionately the ones that are getting sick and dying when we do contract these diseases for a whole host of factors, a lot having to do with the social determinants of health and outside factors. It's not just that Black people get it at higher rates just because we're Black. It's because of the forces of oppression and the systemic injustices that we've had that predispose us to being at higher likelihood to have risk factors for why COVID is decimated parts of our communities. But it's understanding it in that context, but also really sharing our experiences, right? Because that's one of the major ways that people trust that this is something that can be helpful for them, is that if they see their family members getting it and doing well once they do
Mhm.
get it. Yeah.
Thank you, Dr. Teverbaugh. And Dr. Vargas, I'm so happy that you earlier mentioned that vaccine technology actually came from us. I think I heard somewhere or read somewhere that it was an enslaved person in the Boston area who kind of taught the slave master, who might have happened to be a physician, about the value of vaccination. And I think when I heard that, it made me feel a little bit better because I trust in indigenous wisdom as much as I entrust science that's not aimed at harming us.
Onesimus, Onesimus, who was the African slave sold to Cotton Mather.
Mhm.
And he, in 1706, taught him about smallpox from Africa. And the practice was called variolation. The fact that this has been something that has been used historically and brought into the present day in terms of African American history and Black history is important. And I think that, to the extent that those traditional methods have now been used and validated in science, we have to, make sure that those of us who are involved in science and medicine hold folks accountable. And so, one of the things that I think I started to allude to at the end was that we also have this series of, vaccine adverse event reporting system,
Mhm,
vSafe, and other things that will allow people who have been vaccinated to report these, and we have to hold our CDC and our FDA accountable to make sure that we have the data on what happens afterwards. And more importantly, we as folks in this country have to get into and stay into care. Okay, and so the other aspect of this is that, like I said before, this isn't over, and so that when we actually do get our vaccines, that we also identify a medical home, that we find a physician and a provider that we trust and stay in care, so that as we go forward, uh, if there's another pandemic, if there's another episode, those areas of access to care that were driving a lot of the disparities that we saw, hopefully will not be as severe. I think from a policy perspective, we really need to go back and take a look at, really what happened in this space. In as I mentioned to you before, in the area around CDU, we have one community hospital for an area that serves 1 million people.
mhm,
And so
mhm,
that when we're in a situation where we do have conditions that need to be treated, and that treatment can make a difference, if we don't have the resources there, then we're going to see these disparities. The good thing about the current political situation is that, $1.9 trillion has now been allocated to respond to this. And so we also have to now pick up the mantle and say, okay, we had disparities that were driven by social conditions that this virus has now laid bare. We must not give up the fight to say, here's the things that really led us to be more exposed, bring
mhm,
the resources into our communities. The work that you do around secondary trauma, we're gonna, have to deal with the fallout from this.
mhm,
And so people who have been traumatized by the loss of their loved ones, that's often surface level. The trauma of people not being in school for a year, losing their jobs, the disruption of isolation for over a year, the mental health consequences associated with this, all of those things are going to require a very, a large and massive response so that we don't have the secondary effects of COVID-19. And so with that being said, I think, the other thing we have to think about, as we move forward that really has very strong historical racial constructs behind it is how we deal with resource allocation, both to prevent this from causing more disparities in the future. So those areas that didn't have hospitals and death rates were higher, we need to put resources there. Those
mhm,
people that didn't have healthcare providers, that they couldn't get access to care in time, we need to put resources there. Those people who have had to deal with an excess burden because their communities were getting wiped out, we have to make sure that they have mental health services and support. And so, yes, we got to take care of ourselves by getting a vaccine. We have to get into care so that in the future, if something comes up, we have providers that we can reach regularly. And then those of us who have the strength and the agency to advocate, we have to push for these policies to make sure that the resources come to our communities so that we actually deal with the fallout and don't have to deal with disparities moving forward.
Thank you so much, Dr. Vargas. And in that, I just want to add, and then Dr. Teverbaugh, if there's something else you want to say, but we have to trust Black physicians. Black physicians have been here, have been part of our communities, have advocated for us. We now have evidence that shows that in certain areas, we do better when our physician is Black. As a community, we're going to have to trust each other. You've said earlier, talking about pipeline programs, we need more Black young people interested in medicine and becoming doctors. And, this is long term. And I'm very, very, very moved by the recent viral post of Tulane medical students at one of the plantations that, saying we are our ancestors' wildest dreams. And so we have to support education, that if we thinking about prevention, support the education of young children, young Black children, so that they can choose to be in these spaces so that we can develop more trust, that we have our best interest at heart. So Dr. Teverbaugh, I'm going to give you the last word.
I'm a silver lining type woman. So, and I echo Dr. Vargas's overview of what we can do moving forward to make sure that we have health equity and that we have health outcomes that are better in the future, and that we can utilize some of the things that we have learned during the COVID pandemic that have worked, including the expansion of telehealth services and what access that's given to our communities, and use that. So advocate that we get to keep that, right? That insurance panels still cover services delivered through the telehealth portal, because not only does it expand access to care for individual people at the individual level, it's easier for them to see their doc if they don't have to worry about transportation and moving their schedules around as much to get to the doctor's office. But it also, from a geographic, those geographic regions that don't have access right now, and before having to build a physical building, we can give care to them now and they can receive care. So there are some things that we can do and things that have happened as a result of COVID that we can use. And that's just one of them.
I want to thank you all so very much. You, to me, are just amazing Black physicians. You make me proud. I'm the old doc here, and it's just so good to see that you're such young, competent, but most important, caring and compassionate physicians. And I do think that as our faces grow and our communities see us, they will be able to trust that we have their best interest at heart. And there would be no reason why I'm convening a conversation about vaccines if I didn't think that it was going to help prevent some of the mortality and morbidity. So I want to thank you so very much. And as you said, let's use social media and let our community know about what we have just talked about today. So thank you so much.